Alterations in cardiac output and tissue perfusion, infectious and inflammatory disorders. Rheumatic fever and rheumatic carditis. Rheumatic fever will follow a group A streptococcal infection, while rheumatic carditis is an inflammatory cardiac manifestation of rheumatic fever. These clients may have a mild fever, a rapid heart rate and abnormal rhythm, a red spotty rash on their trunk that disappears quickly and leaves irregular circles on the skin. Their joints may be swollen, warm, red, and painful. They may have a heart murmur and pericardial friction rub. We would diagnose it with an ESR, or the erythrocyte sedimentation rate, an ECG, or a C-reactive protein. Medically, we would give IV antibiotics such as penicillin, vancomycin, or Zithromax. We might do surgery for a constrictive pericarditis or damage to the heart valves. We would also administer aspirin for clot prevention, steroids, and prophylactic antibiotics. As nurses, we need to administer prescribed drug therapy, do diversion activities, bed rest, and prophylactic antibiotics. With infective endocarditis, this is inflammation of the inner layer of the heart tissue. It's an autoimmune response to microorganisms that will include bacteria, streptococci, and staphylococci, or fungi. It can be caused through prolonged IV therapy, insertion of cardiac pacemakers and cardiac catheterization, and even Foley catheters. These clients may experience fever, chills, muscle aches, joint pain, ossular nodes, splinter hemorrhages, Janeway lesions, Roth's spots, petechiae, enlarged spleen, and heart murmurs. These clients may have anemia, leukocytosis. We would do blood cultures or a transesophageal echocardiography and ECG. We would administer high doses of antibiotic therapy intravenously, encourage bed rest, and do valve replacement. Nurses need to make sure activity is limited, assess for changes in the client's weight, heart rate, and rhythm, and administer antibiotics. So which of the following histories of a client would relate to a diagnosis of bacterial endocarditis? Strep throat 4 weeks earlier. Remember, bacterial endocarditis is usually going to be associated with some type of streptococcus infection. Myocarditis is inflammation of the muscle layer of the heart. It can be viral, bacterial, fungal, or a parasitic infection. These might include the Coxsackie viruses A and B, influenza A and B viruses, measles, mumps, or the Epstein-Barr virus. These clients may experience a sharp stabbing or squeezing chest discomfort that resembles myocardial infarction. Sitting up should relieve the pain. They may have a low-grade fever, tachycardia, or dysrhythmias, dyspnea, fatigue, cyanotic skin, crackles. An S3 galloping rhythm might be auscultated. We would do a white blood cell count, a C-reactive protein, an echocardiogram, chest x-ray, echocardiography, radionuclide, or biopsy. These clients require bed rest, sodium-restricted diet, cardiotonic drugs such as digitalis, and may even require a heart transplant. Nurses need to monitor the cardiopulmonary status, vital signs, I&O, daily weights, lung sounds, oxygen saturation, maintain bed rest, and administer oxygen. There's three types of cardiomyopathy. We may have a dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. The heart muscle will lose its ability to pump blood efficiently. With dilated cardiomyopathy, these clients will have dyspnea on exertion when they're lying down, fatigue, leg swelling, and palpitations. With hypertrophic cardiomyopathy, these clients may experience syncope, chest pain, or they may be asymptomatic. And restrictive cardiomyopathy will show exertional dyspnea, dependent edema in their legs, ascites, and hepatomegaly. We can diagnose this with chest x-rays, ECGs, echocardiogram, a cardiac MRI, and cardiac catheterization. These clients may require diuretics, digitalis, antihypertensives, antidysrhythmics, anticoagulants, corticosteroids, and dietary sodium restriction. Surgically, we may have to insert a pacemaker, defibrillator, do a ventriculomyomectomy, transplant, heart transplant may be required. Nurses need to obtain a significant or thorough medical and family history, perform a physical examination, obtain vital signs, listen to lung sounds and heart sounds, monitor for edema and abdominal enlargement, monitor the oxygen saturations, monitor the cardiac rhythms, provide oxygen therapy and emotional support. Pericarditis is inflammation of the pericardium, and it can be primary or secondary. It can be secondary to endocarditis, myocarditis, chest trauma, an MI, post-cardiac surgery. It can also be caused or secondary to a cardiac tamponade, which is acute compression of the heart, and pulsus paradoxus. These clients may experience fever, malaise, heaviness in the chest, precordial pain. Moving and breathing will worsen the pain. Sitting upright and leaning forward is going to help relieve the pain. You may auscultate a pericardial friction rub, and they may have severe hypotension. Diagnostically, we would look at the ST segment of the ECG. It would be elevated. The chest X-ray, echocardiogram, white blood cell count, and ESR may also help diagnose. Medically, we need to encourage rest, provide analgesics, antipyretics, NSAIDs, and corticosteroids. And surgically, pericardiocentesis, pericardiostomy, pericardiectomy, or decortication. Nurses need to assess for pain, auscultate heart sounds, assess for jugular vein distension, monitor for a persistent cough, dyspnea, fainting, anxiety, and changes in pulmonary function. So a client with pericarditis has been admitted to the cardiac intensive care unit. The nurse caring for the client knows that the most common clinical assessment of pericarditis is what? Select all that apply. It would basically be all of the above. Thrombophlebitis is inflammation of a vein that's accompanied by a clot or thrombus formation. We may see a deep vein thrombosis or a pulmonary embolus. The inner vein will be irritated or injured, and platelets can clump together and form a clot. We may see the Virchow's triad, which includes venous stasis, altered blood coagulation, and trauma to the vein. These clients may complain of discomfort in the affected extremity, calf pain that increases on dorsiflexion, which would be the positive Hohmann's sign, heat, redness, and swelling, and capillary refill that is less than 2 seconds, fever, malaise, fatigue, and anorexia. We diagnose with a Doppler ultrasound, venography, or impedance plethysmography. Medically, we do encourage ambulation, which is contradictive to previous recommendations of total bed rest. We may apply compression bandaging. We would do anticoagulant therapy or continuous warm wet packs. Surgically, we may do that thrombectomy or ligation. Nurses need to assess for a history of blood clots, their risk factors. Obesity, contraceptive use would be 2 of those. Assess for the Hohmann sign or pain and tenderness in the calf. Assess capillary refill, and assess for pulmonary embolism, which would include a sudden chest pain and dyspnea. Thromboangiitis obliterans is also known as Buerger's disease. It's an inflammation of blood vessels that are associated with clot formation and fibrosis of the blood vessel wall. Assessment findings would include the extremity being cold, numb. They may have burning or tingling in their feet, intermittent claudication, leg cramps after exercise, pain at rest, cyanosis and redness of their feet and legs. The skin may be a mottled purplish red and appears thin and shiny. They have sparse hair growth and black gangrenous areas on their toes and heels. We need to restrict their tobacco, do Buerger-Allen exercises, provide analgesics, or do a sympathectomy. Nurses need to obtain a significant history, monitor for pain. Does the pain increase or decrease? Examine their extremities, their nails, skin temperature, peripheral pulses, and capillary refills. Now I'm also going to insert information on a disease process called arteritis. Arteritis is inflammation of the arteries, and it damages the blood vessel walls, reducing blood flow to the organs. Symptoms and complications will depend on which arteries are affected and the degree of damage. Tachyosus arteritis is also known as aortic arch syndrome or nonspecific aortarteritis. And this is where the walls of the aorta will grow thicker, and it leads to insufficient blood and oxygen supply to the rest of the body. Complications might include loss of vision, cardiac disease, hypertension, fainting, joint pain, muscle pain, fatigue, malaise, fever, night sweats, and weight loss, along with aortic aneurysms. Giant cell arteritis, or GCA, is also known as temporal arteritis. It's an infection of the superficial temporal artery and other arteries that supply blood to the head, eyes, and jaw. GCA will generally start out with flu-like symptoms, and it includes a severe headache, fever, aches, loss of appetite, and malaise. Complications can result in vision loss, jaw pain, scalp pain, and other symptoms. Polyarteritis nodosa, or PN, is an inflammation of the medium and smaller arteries that carry blood from the heart to organs and tissues. Symptoms would include a headache, fever, muscle aches, joint aches, fatigue, weakness, loss of appetite, rashes and sores that might look like bruises, pain that is a burning, numbness, weakness in their hands and feet, renal failure, high blood pressure and edema, heart attacks, heart failure, or pericarditis. It has an unknown cause, but it's believed to be an autoimmune disorder. We may treat it with corticosteroids, antibiotics, or surgery. Most of these people are going to make a recovery, but treatment might take a year or two. So a nurse is educating a client on the causes of Buerger's disease. Which of the following would indicate a client's understanding of the disease process? The condition is associated with smoking.